Good morning. Good morning. Good morning. Okay, we have a little bit of a feedback. Let's try that again. Good morning, and welcome to another educational session brought to you by your Department of Continuing Medical Education. Before we begin, let us start as we usually do with a word of prayer. Father God in heaven, we come before you this morning, thanking you for a beautiful day, thanking you for another opportunity to learn together as colleagues. We thank you for the presenter who will impart her knowledge to us. We pray that you open our minds that we may receive the knowledge and use that knowledge to do good for our patients. Bless us now, this we pray in Jesus' name. Amen. This morning, I am excited to introduce our speaker. Our speaker for this morning is Dr. Sharifa Frederick. She is a distinguished obstetrician, gynecologist, and reproductive medicine specialist based in Kingston, Jamaica. She serves as a consultant at the Hugh Winter Fertility Institute at the University Hospital of the West Indies, where she dedicates her practice to assisting individuals and couples facing fertility challenges. Dr. Frederick earned her Bachelor of Medicine, Bachelor of Surgery degree from the University of the West Indies, Mona. She completed her residency in obstetrics and gynecology, followed by a fellowship in minimally invasive surgery and reproductive medicine at UHWI. Her passion for reproductive health was inspired by her father, Professor Joseph Frederick, a pioneer in assisted reproductive technology in Jamaica. Under his mentorship, Dr. Frederick developed a deep commitment to fertility care, aiming to provide equitable access to reproductive services. Dr. Frederick is also the clinical director at the Caribbean Fertility Center, where she practices and oversees a wide spectrum of reproductive health services. She has been instrumental in promoting awareness of reproductive health issues, including endometriosis, through public education initiatives. She has a passion for expanding the wealth of research output in Jamaica and has been published in journals such as Fertility and Sterility. Outside of her professional life, Dr. Frederick enjoys spending time with her family and has interest in interior decorating and culinary arts. Please welcome today Dr. Sharifa Frederick. Dr. Frederick?
Good. Good morning, everyone. Thank you for inviting me to present a topic that's very dear to my heart. It's very nice to connect with fellow colleagues across the Caribbean. Bahamas is a very beautiful country. I hope that next time I'll be allowed to possibly present in person. Okay, please allow me to share my screen. Am I supposed to advance? Am I able to share?
Yes.
Okay. Okay. Morning, just checking if you're able to see the screen.
Yes, we can. If you can just enlarge it a little bit for us.
Okay.
And presenters, not presentation view.
Okay. Which is this? Okay. Is that better?
Yes, thank you.
Okay. Okay. All right. Today we'll talk a little bit about modern strategies in the diagnosis and treatment of infertility. Okay, infertility is a very real and common problem all over the world. It affects about 13 to 15% of couples. It is usually defined as a failure to conceive after 1 year of regular, unprotected intercourse. That's a general definition of infertility, but of course, this definition has to be tailored to suit the age. So, in persons who are trying to conceive, of course, at the later spectrum of the reproductive spectrum, those are persons who we will identify as being infertile before this year and start evaluating these persons prior to this threshold. So usually if it's a person over 40 years of age, I would start investigating them ASAP if they present to me with a history of 6 months of trying to conceive. Primary infertility applies to those who have never conceived, never had a pregnancy in life, whereas secondary infertility designates those who have at least been pregnant at least once in the past, even if it hasn't culminated in a child. The incidence of primary infertility has increased over the years with a concurrent decrease in secondary infertility. And this is most likely as a result of social changes, such as women and men delaying childbearing. Now, the reason why the threshold of 1 year was coined was because approximately 90%, if a couple is having regular intercourse, whether or not they intend to have the intention is to conceive, if you're having regular unprotected intercourse, you should conceive within a year. And this is a very important statement because I have a lot of couples who come to me and they say they've only been trying for 6 months. They've been trying, they want to have a child and they've only been trying for 6 months. And when I say to them, how long have you been having unprotected regular intercourse? They may say, some have said, well, 4 years or ever since we've been married. And that means that they have been unintentionally trying to conceive for this 4 year gap. And so this, sparks a red flag. 20% of couples will conceive within 1 month, 50% within 3 months, and 75% within 9 months. Infertility has become an increasing problem worldwide. And this is because women and men are, well, women are pursuing careers and men also are delaying childbearing. And so a lot of women are coming in the latter part of the reproductive spectrum. And in this latter part, the infertility rate is increased. So you are less likely to be able to conceive when you're age 40 and above. And as you can see in the pie diagram, at the fertility center I work at, you can see that 21% of patients are between 40 and 42, and this is presenting to an infertility clinic. And 32% of our clients are 43 and over. So 50%, about 50% or a little bit over of the clients that present for infertility care are actually 40 years and older. And at this age, it is a real problem because now we're dealing with a decline in ovarian reserve. And IVF sometimes cannot even help these persons because the IVF success rate is about 10% in women between 42 to 44%, 44 years of age. And so here's a real problem. Now, what is the etiology? What is it? the etiology in terms of the male, the female sex. So 30% of the clients have only male factor, 30% only female, and 30% both. 10% of that population are unexplained. We cannot find a cause. So we've done all the investigations and we can't see what is the reason why conception hasn't taken place. One of the reasons that we've been finding is that it could be because the sperm is just unable to penetrate the egg. And in these cases, it's only treatments such as ICSI or intracytoplasmic sperm injection, which is a component of IVF, is the only solution to the problem, because it's at this point where we actually forcibly inject the sperm into the egg. All right, so just some general points in terms of how do we evaluate the female who presents with infertility. So we have to try to identify what is the root cause of the infertility. So of course, we take a menstrual history. We try to find out if there is any dysmenorrhea, how severe it is, what is her pain scale? Does she have a lot of bloating? Does she have pain during intercourse, pain during passing urine, stool? Has the pain started? Did it start cyclical and now has become chronic? And these are some of the things that can point to a history of endometriosis, which is a very significant causative factor in terms of infertility. Has the patient had previous surgery for endometriosis or for anything of any other kind? We want to find out, does she have uterine fibroids? So we ask about, does has the abdomen increasing in size? Does she have any compressive symptoms? So we try to identify the location. And, histories such as heavy menstrual bleeding can point to uterine fibroids and can actually point to or give you an idea as to where the fibroids are located in terms of heaviness of bleed. That would more likely, if it's heavy, it would more likely indicate that it is somewhere close to the uterine cavity, which is causing inflammation and also increasing the surface area of the endometrium, causing the heaviness of the bleed. Has she had a history of a previous myomectomy? You can take a history to find out, has she had any previous sexually transmitted infections, any previous exposure? How many partners has she had? Does she have any previous pregnancies, such as ectopic pregnancies? In her pregnancy, what was the mode of delivery? How many miscarriages has she had? Did she have a tubal ligation? And sometimes you cannot ask about a tubal ligation in front of a new partner because she may not be forthcoming with information. So sometimes you may have to ask these questions when you're actually by yourself with the patient in the examination room. Does she have any previous terminations? Because this can impact, especially if it's a surgical termination, on your endometrial cavity, causing adhesions, which can contribute to infertility. Another important area is asking questions related to ovarian reserve. Does she have, what is her age group? What does she have menopausal symptoms? And remember that menopausal symptoms can begin as early as 35, especially if this lady has premature ovarian failure. So we also have to ask questions related to the extreme of the spectrum, which is polycystic ovarian syndrome symptoms. Does she have facial hair? Does she have irregular periods? Has she put on weight recently? Because she could have PCOS, but if she's slim, she's subclinical. But as she puts on weight, she now starts to exhibit the clinical symptoms of PCOS, which is a facial hair, the irregular cycles. You also need to ask about any previous infertility treatments and their outcomes. So this can guide you as to how to pave the way forward. Chronic illnesses is also a major part of your history because autoimmune diseases can be significant in terms of what kind of medication is being used to treat the autoimmune disease. And autoimmune diseases can also, unfortunately, affect your ovarian reserve. What kind of medications has this patient been on as well, and how impactful can this medication be on her ovarian reserve? Um, all right, so we also have to ask history and infertility history related to the male counterpart. What are the sexual practices? What is the regularity of intercourse? If you're having intercourse once a month, this may not be conducive to timely conception. um you have to ask the male, what is she able is he able to have an erection? Can he sustain an erection? And does he have an ejaculate? Does anything come out when he ejaculates? Because you can have a case where you ejaculate and absolutely nothing comes out. What are some of the what you have to delve into his lifestyle? Substance abuse. What is the regularity of alcohol abuse? What do they smoke? What do they vape? Are they on testosterone therapy? I've had patients who have come in with low sperm counts and their doctors have put them on testosterone therapy. This is an absolute no-no and can cause a deleterious effect on spermatogenesis. What is his occupation? Does he have an exposure to excessive heat, radiation, chemicals, pesticides? These are some of the things that we need to ask about. Does he have any past surgical history? A history of undescended testes is related to male infertility, as well as sadly, inguinal hernia repairs are associated with decreased spermatogenesis or decreased exit of the sperm in outside, in an ejaculate. Did he have any previous history of a varicocele and varicocele surgeries? Has he had a vasectomy, a prostatectomy? Previous illnesses are also important. You have to ask about a previous orchitis, previous history of mumps as a child, and also trauma to the genitalia. Torsion of the testes is also an important question to ask. We need to also delve into the chronic history of the male as well. As we know, diabetes and medications to treat chronic illnesses can impact the male's fertility. Things like diabetes can lead to retrograde ejaculation, where the ejaculate is now found in the urine rather than coming out of the penis. Autoimmune diseases in the male is also a very important question to ask about, and also the medication which is used to treat these autoimmune diseases. Has he had a previous infection, which can cause obstructive issues, as well as any prostatatic infections? You ask about, do you have any burning on urination, any blood in the urine, etc. Congenital bilateral absence of the vas deferens is also something to inquire about. Medications, ketoconazole, spironolactone, medications can also impact on the male's fertility. On physical examination of the man, we need to ask about whether he has met his milestones in terms of sexual characteristics. We have to also ask about examine the patient and look at the testicular size, whether there's any fluid in the testicles, increased varicosities. A rectal examination should also be done to examine the prostate for enlargement and irregularity. Okay, so investigations. What are some of the investigations that are important in modern day practice when we're looking at the infertile patient? And one of the things that are very important is to look at the anti-Müllerian hormone level. As a matter of fact, I believe that once a patient reaches in her 30s and hasn't had a child, the anti-Müllerian hormone levels should be an investigation that is routinely done, even in somebody who is not seeking to conceive, but may want to conceive later at some point. The AMH has the advantage over the other traditional hormonal assays in that it can be measured at any time in the cycle. When we compare it to the FSH, LH, estradiol trio, which was when I started practicing infertility. That is how we used to investigate for ovarian reserve. You used to send the woman for a day 3, so in the follicular phase, follicular stimulating hormone level, LH level, and estradiol. Estradiol is important because if the estradiol levels are very high, it will abnormally push down and falsify your FSH levels. So your FSH should be less than about 10, but if your estradiol levels are high, then it will appear to be normal in this circumstance. So you have to make sure that you do all 3 and you do it in the follicular phase, which is really day 3 of the menses. Nowadays, AMH levels have trumped this trio, and that has become now the gold standard in investigating ovarian reserve. The normal AMH levels are shown in the chart, and you can see that as you age, yes, your AMH level will fall, and the AMH is directly related to your reproductive outcomes. Some other hormone investigations which are important in the initial investigation of a patient is your thyroid hormone, thyroid stimulating hormone levels, your prolactin levels, and if I suspect endometriosis, I always do a CA-125 as it will be elevated in patients with endometriosis. So the anti-Müllerian hormone level is always done in unison though with your antral follicular count. Your antral follicular count are basically the follicles that exist in the ovaries. They are recruited every month, and every month you can see these follicles as they measure between 2 and 10 millimeters. Now, when I do an ultrasound and I count the follicles in each ovary, if they add up to between 8 to 24, you can safely say that the patient has normal ovarian reserve. You use it though in conjunction with your AMH. Reason why an antral follicular count is important is that for some reason, some patients can have normal anti-Müllerian hormone levels, but when you do the antral counts, they're very low. And it's the antral count that now will supersede the AMH level. And this is what will be important in determining the prognosis and the ability for this person to have a child. Now, if the antral follicular count is greater than 25, this indicates that the patient has polycystic ovaries and may have the syndrome if she also has the symptoms. If the follicular count, when you add the right and the left ovary, is between 4 to 7 follicles, you can see that this patient possibly has low ovarian reserve. If she has less than 4 follicles between the 2 ovaries, then she has a very low reserve and hence a very poor prognosis in terms of conceiving. Other investigations which are important in terms of the ultrasound is in looking for uterine abnormalities. Large uterine fibroids, especially if they encroach on the cavity, this can affect implantation. So the patient may be having intercourse, fertilization may be taking place, but implantation may not be possible because of uterine fibroids. Even adenomyosis may pose a problem because it may cause an elevated pressure inside of the uterine cavity and prevent implantation. Things like polyps inside of the cavity are also important things to identify because they may need to be removed before the patient can conceive. Now, endometriomas, which is endometriosis in the ovaries, are also important things to look for at the time of ultrasound. Hydrosalpinges can be seen at the time of ultrasound only if they are large. And this is what it looks like on ultrasound. If you look at the picture on the side, only if it's very extensive and large can you see a hydrosalpinx on ultrasound. So if you suspect it, you're not seeing it on ultrasound, then you need to resort to other means like an HSG, which I will discuss later. Now, at the time of ultrasound, because the cavity is collapsed on a regular transvaginal ultrasound, you can miss polyps, you can miss some submucosal fibroids. So a more sensitive form of investigation by ultrasound is by doing an SIS, which is a saline infusion sonogram. It is more sensitive than a regular transvaginal ultrasound, and it can help to identify intracavitary masses, which I had mentioned before, things like polyps and submucosal fibroids, which may be missed at the time of a regular transvaginal ultrasound, and it may help to identify adhesions. And basically, what is done is the patient under sterile procedure, cervix is cleaned, a catheter or feeding tube is placed into the uterine cavity, and saline is infused into the cavity, and the cavity blows up like a balloon. And you're able to delineate the endometrium very clearly and see if there's any things projecting off the endometrium, which may represent a polyp or fibroids. Sometimes, if the cavity doesn't distend well, it may indicate that this patient has adhesions inside of the cavity, or you may actually see adhesion bands inside of the cavity at the time of the SIS. So it's a very good diagnostic tool to use in investigating the infertile patient. Now, the gold standard for investigating the cavity of the uterus is actually a diagnostic hysteroscopy. So if you find an abnormality at the time of ultrasound or saline infusion ultrasound, you may want to do a diagnostic hysteroscopy, which is a minimally invasive surgical procedure where a camera is inserted into the cavity, and you can actually now see these structures in real time. And this at the side is a hysteroscopic evaluation of a patient where you see a endometrial polyp, and you can actually use a grasper and remove it from the base and completely remove that polyp at the time of the diagnostic hysteroscopy. Now, other investigations which are extremely important in analyzing or in investigating the infertile patient is an HSG, which is a hysterosalpingogram. Other newer forms of investigating tubal patency is called a HIFO-C, which is basically using an ultrasound now to, instead of the HSG, which is using X-rays. So the HSG, you use a contrast, you insert it into the tubes, into the uterus. You push it under pressure, it fills up the tubes, and you take X-ray pictures, and you can actually see how the contrast um, um, delineates the endometrial cavity, so you can find abnormalities at that point. But then you're really looking at the tubal patency, so you're looking to see how the dye enters into the tube, fills the tube, and then spills into the peritoneal cavity. And once you have achieved this bilaterally, you can say that she has normal tubal patency. Now, this procedure can be, a lot of patients say it is very painful because the dye can initiate spasm of the tubes, and sometimes it can cause the tubes to actually, because if the spasm gets so severe, the tubes can now close off and appear to be blocked. So other ways of investigating for tubal patency include the hysterosalpingo foam sonography. So this is where the gynecologist now will insert a foam into the uterine cavity, and on the ultrasound, we're able to see how the foam fills the tubes and spills into the peritoneal cavity. Now, when you compare HIFO-C with an HSG, it has been shown that it is just as sensitive, it's well tolerated, it's safe. Actually, the patient has a better comfort level or score when we compare HIFO-C with an HSG. There has been now an urge now to change the official guidelines to include HIFO-C as the first line tool of assessment of tubal patency over the HSG. Now, if you do any one of these procedures and you're still unclear as to whether the tubes are blocked or not, you can ask the patient to do a diagnostic lap and dye insufflation, where you actually insert methylene blue into the uterine cavity, and you can actually observe spillage, observe filling and spilling of the tubes into the peritoneal cavity. Now, one of the things that I have found to be very important in the investigation of the infertile patient is to do an STI 9 or 11 panel, where they actually look for the DNA of organisms such as gonorrhea, trichomonas, chlamydia, and um, one of the organisms that have become very topical is the urea plasma, because parvum or or herbum, a lot of sorry, a lot of persons will say that urea plasma is a commensal. So urea plasma can exist in the uterine cavity. Patients can get pregnant if you have urea plasma. However, it can cause problems in patients who are doing IUI, intrauterine insemination, as well as IVF. And one of the things that I have found is that patients may become pregnant naturally with uroplasma because, as you remember in biology, the embryo is being fertilized in the tube and is coming from the tube and being implanted into the cavity. However, when we are doing treatments such as an intrauterine insemination or IVF, where we're now taking the embryo and taking it from the outside, or the sperm from the outside, and introducing a catheter into the cavity, we are now moving organisms from the reproductive tract, from the vagina, from the cervix into the uterus, which is supposed to be a sterile environment, and we can now introduce inflammation, and this can also impact or have a negative impact on implantation. So it's very important to do an STI9 panel for that reason, as well as to treat other sexually transmitted infections, which may later on cause tubal issues, tubal disease, tubal blockage. Um, we have now been finding that uroplasma contributes to, as I said before, failed implantation, even if they do get pregnant naturally, early miscarriages, fetal loss, poor quality egg, and so it negatively impacts reproductive outcome. I'm yet to do more studies on ureaplasma because it is a very interesting organism as it relates to fertility. Okay, some of the investigations for the men we want to do, of course, the gold standard is the traditional semen analysis, where the man is asked to produce a sample, we put it in a container, and then we place a droplet of the sample under the microscope, and we examine the sperm looking for movement, morphology, and count. Now, one of the newer modes of doing a semen analysis is by using a CASA, which is a computer assisted form of semen analysis. It's generally accurate, but there's room for misinterpretation, especially if there's a high component of debris in the sample, or if the count is very low. We will then need that human component to assist in analyzing the semen. In both, the male will be asked to abstain um, after releasing for 3 to 5 days, because if they give a sample within this time, it can affect remarkably the volume and of course the count. Now, the WHO guidelines in doing a semen analysis hasn't really changed much since 2020, the 2021, 2022 guidelines. And just simplistically, they look at the volume, which should be between 1.4 to 1.5 mils. The concentration should be greater than 15 to 16 million sperm per mil. The total motility between 40 to 42, and you should have more than 4% normal morphology in your sample. Now, just quickly, some terminology which a lot of people get a little bit confused with. So, oligospermia is a low semen volume, which you can get if the person gives a sample within 3 to 5 days or of sexual intercourse or producing a sample prior. Oligozoospermia is just a low count, so it's a count less than 15 million per mil on semen analysis. Aphenozoospermia is when you have a decreased motility, less than 40% motile. Teratozoospermia, when you have greater than 4% of abnormal sperm morphology. And azoospermia, which is something that we really don't like to talk about, or the men don't like to hear of as a diagnosis, is the absence, a total absence of sperm in the sample. And unfortunately, this affects about 10 to 15% of infertile couples that come for a semen analysis. Now, if azoospermia is diagnosed, the sample should be repeated. We don't just use one sample to make the diagnosis. And of course, psychological support becomes very important in this circumstance. Now, azoospermia can be obstructive, where there's an obstruction in the exit of the semen, most likely the vas deferens, or it can be non-obstructive, where there's a problem with sperm production. All right. And azoospermia is the absence of semen totally. And so if this exists, you have to look towards retrograde ejaculation. Now, some of the other investigations that should happen, especially if there's azoospermia, there's a little spelling error there, typo. If there's azoospermia or severe oligospermia, then you should follow through with doing a follicle stimulating hormone for the man, luteinizing hormone, testosterone levels, as well as prolactin levels. If you suspect that if you suspect that the person has diabetes and retrograde ejaculation, you should look for diabetes mellitus. You should check the patient for whether he has diabetes or not. Um, DNA fragmentation is also a tool that is being used now to investigate patients with especially severe oligospermia, or persons who have a normal sperm count, but you notice that fertilization rates, especially if you're doing in vitro fertilization, are very low. This could indicate that there is a sperm DNA fragmentation issue. And it is a test where if you have more than 15% of the DNA being fragmented, you know that there is an issue. Fairly recently, we had a couple they were doing IVF, and they had a very poor outcome with donor sperm. So the semen analysis showed that yes, there was oligospermia, but it wasn't severe. But because of the poor outcome, we suggested that they do a DNA fragmentation, and we found 100% of the sperm had fragmented. And so we know that this man, despite not having severe oligo, has a severe issue with his sperm. All right. Now, if you have a patient who comes in with cystic fibrosis, or who has a history of having some sort of genetic issue or repeated miscarriages, then we should do a blood test and investigate, do a karyotyping for this man to look for microdeletions or cystic fibrosis. Now, if when we investigate the male and we do the FSH, LH, and testosterone and prolactin levels, this can help in diagnosing what is the problem in terms of the azoospermia. All right. So if you do the FSH, LH, testosterone, and prolactin levels, you can you can diagnose if there is complete testicular failure. In that regard, you would have a high FSH, high LH, normal or low testosterone, and normal prolactin. If you have a problem at the level of the brain, for example, hypogonadotropic gonadism, that means he's not producing enough follicular stimulating hormone or luteinizing hormone, and so you will have low FSH, low LH, as well as low production, because now the testicles or the spermatogenesis is not taking place, and so testosterone as well would not be produced. So in doing the hormonal panel for the male, it can help to diagnose exactly what is happening in terms of what is the source of the problem. Now, the As you can see, the STI-9 panel is also an important investigative tool in the male, and we do a urine test to see if he has any sexually transmitted infections which need to be treated. And we also treat ureaplasma in the male because we've found that it has become associated with decreased sperm motility, lower sperm counts, and a high DNA fragmentation, which may affect fertilization. Now, how do we manage the infertile couple? So the management of the infertile couple will involve a holistic approach and a multi-specialist approach as well. So we need the counselor to be involved to give psychological support. We would need the reproductive endocrinologist, the supporting gynecologist. We need sometimes an embryologist. Sometimes we need a geneticist. So the management is taking a holistic approach and sometimes adjuvant therapy. So we ask, the persons who practice acupuncture, Chinese medicine to come and assist, as well as I always use supplements in patients who present for infertility. So standard supplements in all patients who are trying to conceive include things like vitamin D3, omega-3. In managing the patients, we also address lifestyle changes. So if there's obesity involved, we encourage the patient to eat well, to exercise. Exercise also increases the blood flow to the reproductive organs. We find that persons who are athletic have a better prognostic score than those who are sedentary. So lifestyle changes. If they are hard smokers, if they are hard drinkers, we encourage them to refrain from that sort of lifestyle. Make some healthy lifestyle changes once they're trying to conceive. We also try to treat the underlying cause. So if there's endometriosis, uterine fibroids, whatever is the underlying cause, it has to be addressed. And we also, what is very important is to take an individualized approach to each couple. So what are some of the medical treatment modalities that are useful in men who suffer from low sperm count or poor motility or some sort of morphological problems or DNA fragmentation, which is high? One of the things that we have started to use, which is off-label, is tamoxifen. And we have found tamoxifen is a selective estrogen receptor modulator, which is used to treat males who are suffering from infertility. We usually use a dose of 20 milligrams per day. And tamoxifen, what it does is that it decreases the negative feedback of estrogen. And so you get an increase in the gonadotropin releasing hormone level, luteinizing hormone level, FSH, which enhances the biosynthesis of testosterone and hence stimulates spermatogenesis. Tamoxifen has also been found to protect the sperm from reactive oxygen species and enhances mitochondrial function, cellular function. Clomiphene is also useful, has been found to be useful, and it is also a SERM, and it's used at a dose of 25 to 50 milligrams. And some studies have shown that clomiphene is more effective than tamoxifen. Supplements are also important in the management of these patients. Vitamin C, high dose. I always start males on 1 gram daily. Vitamin D3, as I mentioned before, 5,000 units. Omega-3, which are powerful antioxidants. Any combination of selenium, zinc, L-carnitine. So we have a lot of supplements, which like male sperm count max, sperm motility max, which you can see the supplement facts here, which contain a combination of selenium, zinc, L-carnitine, coenzyme Q can be used. Coenzyme Q10, vitamin E have also been found to improve sperm membrane integrity as well as functionality. So supplements, I strongly believe in supplements, and I believe that they do have some useful impact on improving um, sperm functionality. Now, are there any surgical treatments that are useful in the men? In men who have been diagnosed with varicocele, you doing a varicole, varicocelectomy is useful in treating, because what it does is that when you have dilated veins in the testicle, it can increase the heat production at that level, and so it negatively impacts on spermatogenesis. So the surgical treatment of the varicocele can improve pregnancy rates, even though this is controversial, but I have seen that it is useful in improving pregnancy rates. Now, what about the men who have had a previous vasectomy? Does reversal trump doing now a surgical sperm retrieval and IVF? Studies have shown that if you have a young couple, it's better to do a vasectomy reversal in preference to IVF, especially if the vasectomy has been done in less than 10 years. If you have an older patient, though, an older couple, say you have a woman who is now 39 years old with a partner who has had a previous vasectomy, studies have shown it is better to do IVF compared to a vasectomy reversal. So whether or not you do a reversal depends on the individualized situation of the couple. Now, surgical sperm retrieval is a procedure which is done for patients who have diagnosed, you've done 2 semen analysis and you've now diagnosed azoospermia. There's no sperm in the ejaculate, so now you have to go searching for sperm in the testicle itself. Now, this can be it can be carried out as a diagnostic tool. So I say to couples, we can do a surgical sperm retrieval prior to a treatment, and this is just to know whether or not there is sperm there so you can make an informed decision. Because some patients, if no sperm is found, they make a decision at that point not to go any further with any fertility treatments. Some couples may decide if no sperm is found, they will go ahead and use donor sperm as an alternative. So it is a diagnostic tool as well as a treatment tool. So once you know that sperm is there at the time of SSR, surgical sperm retrieval, you can now plan an IVF cycle in which you would do it. You would use surgical sperm retrieval to find sperm and use it for injecting the sperm into the egg. So there are different forms of surgical sperm retrievals. There is the actual testicular sperm aspiration, where you're using a needle and pulling fluid from the testicle, or you can do teaser, where you actually make a small incision and remove tubules from the testicle, and the embryologist will now crush up the tubules and look for individualized sperm. You can do percutaneous epididymal sperm aspiration, where you're just pulling fluid from the epididymis, or you can do microsurgical technique, where you're actually using microsurgical techniques to actually identify sperm in the epididymis. Now, as I said before, this is done either as a diagnostic tool or it's done during an IVF procedure. In 50% of the case in non-obstructive azoospermia, no sperm is found. And so donor sperm may be an attractive alternative in this circumstance. Now we move on to the female, and we move on to the management of infertility as it relates to surgical procedures in the female. Now, in 15% of patients who present with infertility, 15% of them is due to a peritoneal factor. Some insult to the peritoneum, whether it be adhesions due to pelvic inflammatory disease, or adhesions due to endometriosis, or just endometriosis disease, inflammation, disease, nodules affecting the peritoneal space. This can be the cause of what is causing the infertility. These things can distort normal anatomy, and so you have altered or inability for the tubes to actually pick up or capture the egg which is being released by the ovary. I'll show you a very interesting picture here, which shows the ovary, which is completely covered in adhesions. So you can see in this circumstance, if ovulation were to take place, that egg would be going nowhere. So an operative laparoscopy would be indicated in this circumstance to remove all of this. So you would basically uncover the ovary, remove all of these adhesions, and restore normal anatomy so that you improve ovum pickup by the tube. So this sort of scenario can take place in somebody who has endometriosis as well as pelvic inflammatory disease. Now, in the case of endometriosis, the ovary can have a cyst, which is called an endometrioma. And the dilemma is whether we go in and remove it or we leave it alone. If an endometrioma is greater than 4 centimeters, studies have found that surgery, removing that endometrioma, draining it, removing the capsule, has been associated with improving the success of patients with endometriosis. Now, some of the other causes of infertility include uterine causes, and this is present in about 3 to 5% of cases. So the problem with the uterus can be congenital due to things like a septated uterus, bicoronate or unicoronate uterus, or structural abnormalities such as fibroids, which I mentioned before, which can be submucosal, that's lying within the cavity, or it can be a large intramural cavity, which is in the wall, but is having some impact on fertility by either extending into the cavity, or you can have a fibroid that is lateral to the uterine wall, which can actually impact on the blood flow to the uterus, as well as blood flow to the ovary, which can actually have an impact on ovarian reserve. So that is how fibroids can impact on your fertility. Now, how do you treat these fibroids, or how do you treat these abnormalities? The gold standard for things like congenital abnormalities, septate bicoronate uterus, and submucosal fibroids are operative hysteroscopy. So that's a form of minimally invasive surgery where there are no incisions. We go in through the vagina, into the cervix, into the uterus, and perform surgery, removing the submucosal fibroid or removing that septae in the uterus to improve the environment of the intrauterine cavity. Now, there are other conditions like polyps, which can be removed at the time of operative hysteroscopy, and adhesions such as Asherman syndrome within the cavity that can be removed at the time of operative hysteroscopy. Sometimes as simple as a cervical stenosis can be an issue, and that can be resolved using your operative hysteroscope. Now, if you have large fibroids, and they are shown to impact on your uterine functionality, they should also be removed at the time. However, care should be taken during any operative or any surgical management because you can now change the prognosis by iatrogenically damaging structures at the time of surgery. So it is very important that the person who is doing the surgery is cognizant that this patient is trying to conceive and try to do uterine sparing surgery, avoiding large incisions, multiple incisions, in avoiding blood loss, which can lead to a hysterectomy. It's important to avoid damaging the uterine supply to the endometrium. It's important to avoid damaging the supply to the ovary because inadvertently we have found that there are patients who have come after myomectomy and their AMH levels or the antral counts have fallen significantly, and this could be due to the actual surgical procedure. So care should be taken in performing surgical treatment in patients who are trying to conceive to avoid now tipping them over into a worse scenario than they started off with. Now, 30% of infertility cases are related to tubal issues. And tubal disease can be caused by pelvic inflammatory disease, endometriosis, previous surgery, previous peritoneal infections such as appendicitis or diverticulitis. And of course, if the patient has had a previous tubal ligation before, then of course they now have a tubal issue related to their infertility. Tuboplasty, if the tube is blocked, it is useful in some circumstances. I recommend tuboplasty if there is a minor fimbrial occlusion, or if the patient has had a previous tubal ligation, you can perform tubal reversal. And in this circumstance, the patient can then be offered natural conception. If the tubal disease is severe, meaning there's a component of a hydrosalpinx with it, that's water in the tube, or if the patient is approaching the latter part of a reproductive spectrum, or when speed is required, then IVF is preferred over tuboplasty in these scenarios. Now, the medical management of the female who presents with infertility, as I'd mentioned before, lifestyle changes are important, especially in the obese PCOS patient. Weight loss is highly recommended. Supplements, as you see, I mention supplements all the time because I really believe that they're important. Now, in the case of a high AMH, which can exist in a patient with PCOS, they have a lot of follicles. The granulosa cells of the eggs are what produce the anti-Müllerian hormones. So of course, if you have a lot of follicles, the patient has polycystic ovaries, they will have a high AMH. How do we treat this? Polycystic ovarian syndrome is associated with a poor hormonal environment, which can affect egg quality. And so they should be treated to decrease this problem. And one of the treatment modalities is metformin, which decreases insulin resistance and has been shown to improve the egg quality in patients with polycystic ovarian syndrome. One of the newer modalities is polyinositol, which is a combination of 40 to 1, 40 myo to 1 D-chiroinositol, which actually some studies have shown that it's superior to metformin in improving pregnancy rates in patients with polycystic ovarian syndrome. In these patients, we sometimes use ovulation induction protocols because in PCOS, we know that they sometimes fail to ovulate, which is why they get the the oligomenorrhea or the abnormal cycles. And what we do in ovulation induction is on day 1 of the bleed, when the ovary is quiet, we do an antral count. And on day 2, on day 1, we do an ultrasound, do an antral count, make sure the ovary is quiet, there's no activity, there's no cystic structures in the ovary. And on day 2, we commence the ovulation induction agent, which could be letrozole, or it could be clomiphene, or we could go with the stronger medications, which is the follicular stimulating hormones, which there are many combinations of follicular stimulating hormone formulations, which are HMG, your FSH, your Menopur, your Gonal F. There's a lot of FSH combinations out there. And what we do is we start them on this regime on day 2 of the cycle. We can continue. If they're using oral agents, we use it for 5 days. If they're using injection agents, such as the FSH, we tend to use it for between 5 and 10 days. It's very important that they do a day 9 to 10 scan to see if there is a lead follicle. And at that time, we can trigger them with human chorionic gonadotropin, which helps to mature the egg and help it to ovulate. And 36 hours later, you can let them know that they can have timed intercourse. So that's a form of an ovulation induction protocol. Now, if the patient, so that scenario was for somebody who had a high AMH or a PCOS patient. If you have a patient with a low AMH, or if you know that they failed to ovulate for some reason, Of course, you treat the underlying disorder, you optimize them. If they have a if they have thyroid issues, prolactin issues, you would treat them with the necessary medications. You would do an STI9 screen for them. If you find that they're positive for things like ureaplasma or Gardnerella, you would treat them with doxycycline. That's used to treat the ureaplasma. Flagyl is used to treat the Gardnerella. And you can do ovulation induction agents for these patients. And in some of the older patients, if you diagnose luteal phase defect, meaning the progesterone level is not sufficient in the luteal phase, you may supplement them with 100 to 200 milligrams of progesterone daily after they've ovulated. So these are the clients with a low AMH in using your ovulation induction agents. Now, intrauterine insemination. So before we had spoken about doing time intercourse. Now, intrauterine insemination can be done for circumstances where you have male factor infertility. So if you find that you have a low sperm count, if the sperm count is borderline low, so meaning between 10 to 14, but not lower than this, these are the clients who are indicated for an intrauterine insemination. Or if the client has a poor motility, then you would actually do a intrauterine insemination. And what this involves is that you will take a sample from the male, you process the sample, and then you now place it into the uterine cavity. Usually when you have intercourse, the semen is deposited at the level of the cervix. When you do an intrauterine insemination, the semen, the sperm is prepared so that you actually get pure sperm, because semen contains prostaglandins, and if you place semen directly into the uterine cavity, you will cause powerful contractions of the uterus. And so in order to do an insemination into the uterine cavity, you have to wash the sperm or prepare the sperm. So an IUI is indicated for patients who have low sperm counts, low motility. It's very useful in cases where you have the male partner living in the US, living overseas, and you have a visiting relationship. So you would ask that partner to store sperm, and then you do an IUI. It is useful for serodiscordant couples, couples who are HIV or have any other viral positivities that you don't want them to have unprotected intercourse. You would wash the sperm and you would now place it inside the uterine cavity. It is useful for single women or for couples who have azoospermia and you now want to use donor sperm. And it is the first step of management in the patients with unexplained infertility. It is very useful in patients who have a very poor ovarian reserve, and IVF is not indicated because it is associated with a poor prognosis. So this slide just explains how an IUI is performed very simplistically. You usually get if you get a fresh sample, the patient can produce the sample on site, or it can be produced at home and brought to the lab within an hour. It can also, in patients who cannot masturbate, you can give them a male factor pack, which is a special condom, which place over you place it over the penis. They can have intercourse, they collect it, they knot the condom and bring it to the lab. So they can use specialized condoms in the case of patients who have, a problem with masturbating. We can also do IUI using frozen samples, which are prepared prior to treatment. Now, just very simply, the sperm is washed, and it is basically you use a sperm gradient to centrifuge the sample so that you get a sperm pellet at the bottom of the conical tube. And this sample is what you will have the motile sperm, which will get to the bottom, and all the dead sperm will go to the top. So this is how you get your pure motile sperm pellet to use for an IUI. Now, some modern approaches to sperm preparation include the use of the zymote, which is basically a chamber in which It helps to select the better sperm, which you place the sample in the chamber, and what you will have is the sperm, which is alive and motile, rising to the top, and you just basically take off that top layer to use in your IUI, or you can use it in IVF. So this is a more modernized approach to sperm preparation, which is very simple compared to your centrifugation, and it is actually superior in being able to select a normal sperm with with less DNA fragmentation, better motility for your sample. Very simply, an IUI is done as an office procedure. You basically just need a cleaning agent, you need a catheter and a speculum. You partially fill the bladder, the patient is placed in a lithotomy position. You remove the cervical mucus. You try to avoid the use of a tenaculum to grasp the anterior lip of the cervix. But sometimes if the introduction of the catheter is difficult, you need to use a tenaculum, but this can cause spasm, and actually you can expel some of that sperm sample if you use a tenaculum. But you place the tenaculum into the cavity, you touch the fundus, you pull it back by a centimeter, and then you release the sperm. You ask the patient to rest for 10 minutes. Now, in vitro fertilization is basically the last resort, or it is the resort. It is something that you refer to if the patient has tubal factor that is not amendable to tubal repair. It has a high success rate, which has now allowed extension to couples who have endometriosis, drug-resistant PCOS, and unexplained infertility. It is very useful in patients who have severe male factor, meaning they have a high DNA fragmentation rate, and it is also the only means of having a biological child in patients or men who have azoospermia, whereby you use surgical sperm retrieval to get the sperm. IVF is also indicated in the case of third-party reproduction. So it's indicated in couples, same-sex couples. It's indicated in those who have low ovarian reserve, who you need to offer donor eggs. And it is very useful in patients who, for some reason, have had to have ovarian sparing hysterectomy, where we can now use a gestational surrogate. I seem to be going a little over time, so I'm just going to run very quickly through the rest of the slides. Very simply, what is the procedure of in vitro fertilization? Well, it involves ovarian stimulation or hyperstimulation, because normally in a menstrual cycle, you produce you have release of 1 or 2 eggs. Now we're trying to encourage the development of multiple eggs so that we have more eggs to choose from, because IVF is a numbers game, and the more eggs you have is the more embryos you end up with at the end of the day, and it's the greater the success in terms of a live birth. So we use ovarian hyperstimulation. We use agents such as FSH, and LH to stimulate the ovaries to produce multiple eggs. Then we do what is called follicular aspiration, where under a needle, ultrasound guided needle, we actually pull the fluid from the follicles, which would contain the eggs. We do oocyte preparation and examination, because this can now be a diagnostic tool as to why the patient wasn't getting pregnant. Are the eggs severely affected by endometriosis? You can actually see endometriotic deposits in the follicular fluid and in the egg as well. You would do sperm preparation, which I'd mentioned before, by conventional um, means, by doing centrifugation, or we can use zymote to produce the egg, that chamber that we put sperm that we push the semen through. Or we can use hyaluronic acid binding, which is a newer technique that actually mimics natural egg selection. So it's the hyaluronic acid is exposed to the sperm, and it actually picks out the better sperm, which we can now use for traditional IVF, intracytoplasmic sperm injection, or the PIXI, which is actually the use of the hyaluronic acid binding, and we actually use this to now choose a better sperm. In the IVF preparation, we do what is called embryo culture. So we can culture the embryo for 5 days. We leave it to the blastocyst stage, and that's usually the stage in which we can either freeze embryos, we can do an embryo transfer, or we can do now testing of that embryo, which is called pre-implantation genetic testing, where we can actually now look to see what is the chromosomal makeup of this embryo. And finally, we do an embryo transfer. What's a little bit about pre-implantation genetic testing? It is fairly new on the market. It's been around for several years. Its usefulness is, well, PGT is pre-implantation genetic testing. So this is actually taking cells from the trophoderm layer of the embryo and seeing what is the chromosomal makeup. So there are different types of PGT. There's PGT looking for aneuploidy, and this is just basically screening the embryo, looking for if there are too many or too few chromosomes. And we can now select the better um, embryo to use for an embryo transfer. This is very useful in improving implantation success with IVF, and also it works to decrease miscarriages in patients who have recurrent miscarriages. So this is very useful in patients who we suspect have chromosomal issues, which may be causing their miscarriages. PGTM, which is a monogenetic gene, single gene selection. So basically, it tests specific gene mutations in a single gene, and we're looking for conditions such as cystic fibrosis. It's also very useful in patients with sickle cell anemia, especially if both partner have some component of the sickle cell gene. So it's useful when parents are known carriers of a specific gene disorder. There's PGT-SR, which are basically, it detects deletions or duplications of genetic material, which is caused by structural now chromosomal rearrangements, such as translocations or inversions. And it's useful for patients who have balanced chromosomal rearrangements. New on the market is PGTP, which is which is looking for polygenetic risk, and this is basically assessing the risk or developing a score for complex multi-gene disorders, things like diabetes and hypertension. Now, so it currently lacks strong scientific consensus and legal licensing in some regions, but I see the future of this because it can identify embryos that have these multi-gene disorders. So that's PGT in a nutshell. Now, the treatment of patients with low ovarian reserve this is something that has become very topical, as you know, because we have now more and more patients in the over 40 age group, and these are the patients that are going to have low ovarian reserve. So there are newer techniques which can be used now to improve one's egg quality. There are things such as the use of platelet-rich plasma, which we inject into the ovary, and it has been found to help in the rejuvenation of ovarian function. We have things, third-party reproduction, where we select donors, where we investigate the donors, make sure that they have good ovarian reserve, make sure they don't have diseases such as autoimmune diseases. We screen them properly, do psychological assessment on donors, and we now introduce the third-party reproduction donor eggs to patients who have low ovarian reserve. It's useful for patients who are over 43 years of age, who have had previous IVF failure, and patients who have premature ovarian failure or just very extremely low ovarian reserve. And we're talking about AMH values of zero point 0.5 and under. These are the patients who would be candidates for third-party reproduction. And whereas patients who are over 40 presenting to IVF may have success rates of 10%, when they use donor eggs, their success rates will now be 70% and approaching 95% if you do more than one cycle. Third-party reproductive therapy or donor eggs are useful for patients. And what we have found is that even though the DNA is from the donor, the mother's uterine environment has a powerful role in regulating how the genes of this fetus is expressed. And this is something called epigenetics, which is something that is being studied more and more. And I think patients are more likely to come around when they understand what epigenetics is, and they understand that even though the DNA of the child is from a donor, that their body, their uterus influences the expression of the genes in this child. I believe that it is superior to things like adoption, because when the fetus grows in that womb, the mother will have some sort of bonding and it will have a long lasting effect. So 9 months of gestation allows for the mother to establish a profound direct influence on the child's development, which can alleviate concerns about being not biologically related to that child. Donor eggs can also be used in terms of a third party reproduction therapy, which is called cytoplasmic mitochondrial donation, where we use the mother or the woman who has a low ovarian reserve. We extract eggs from her, but because we find that the most of the problem exists because of the mitochondrial functionality of the egg, what we do is we extract cytoplasm from a donor egg and introduce it into the patient's egg. And so we have found that this can help to rejuvenate the egg. And we have actually, it's not FDA approved in the US, but it's been used in Mexico and in some European countries. And we have so far about a handful, about a dozen babies so far, which have been born using this third-party reproductive technique. Another form of third-party reproduction is surrogacy. And there are two types of surrogacy. There's traditional surrogacy, which is uncommon because in traditional surrogacy, the surrogate is also the biological parent of that child. This is discouraged because it is associated with a lot of legal issues, a lot of emotional and psychological issues, because the surrogate is giving up a child who is biologically related to her. What we more encourage is called gestational surrogacy, which has been found to be more appropriate, because what happens in this circumstance is that the intended parents, they are the ones that produce the egg and the sperm, or they get donor eggs or donor sperm, form an embryo, and this embryo, which is not related to the surrogate, is placed in the uterine cavity of the surrogate. So it's a reproductive arrangement where the carrier carries a child for the intended parent using an IVF created embryo. And so she has no genetic relationship with the baby. It involves investigation of the both parties, the intended parent and the surrogate. It involves the use of a legal contract, medical evaluations, and of course, very importantly, psychological screens. Now, very quickly, we talk about the diagnosis and the management of infertility, but what is very important is how do we prevent infertility? And it starts before the desire to conceive. It starts actually with your general practitioner, your general gynecologist, and it involves one, reducing the risk of STI infection, STI screening, early treating of endometriosis, early monitoring of your AMH levels, and possibly initiating some sort of egg freezing at this point if you identify that the patient is at risk of endometriosis. It is the prevention of intrauterine as well as peritoneal issues by careful surgical manipulations when we're doing surgeries for these patients. As I mentioned before, it involves AMH monitoring your AMH levels. So even if you're not trying to conceive, once a patient is 30 years and over, I recommend checking her AMH level to see if it is abnormal or not. If it is borderline abnormal, then, or borderline normal, I would suggest doing social freezing, putting down some eggs. This is called fertility insurance, making sure that when you, at some point, if you're in your 40s now and then you decide to have kids, at least you have if you have eggs in the bank, which you can rely on if you have difficulty at that point. It is also medical freezing. If you're going to be going on cytotoxic medications, or you have to remove your ovaries for cancer or any other issue, or even in the males, if they are now going to be using cytotoxic medications, they can also freeze sperm, which is basically a form of fertility insurance. All right, very quickly, some takeaways. Infertility is a very common and a treatable condition. So in my view, there's a treatment option for every single infertile couple. It involves early structured evaluation, which helps to improve outcome. Even if a female cause is identified, so we have tubal disease or we have a female with endometriosis, always investigate the male and vice versa. It involves an individualized approach. So there's no commercial approach to any person or any couple with infertility. ART is constantly evolving, as we see with some of the newer techniques, and we always have to keep ourselves up to date with all of the newer techniques which have become available. And the futuristic AI models will help to predict, prevent, and also treat infertility. Thank you.
Thank you so much, Dr. Frederick. You have definitely provided a very comprehensive presentation regarding infertility. And it is so good to know that regardless to the cost, there is a way to provide couples or individuals hope of having a child. So right now, the floor is currently open for questions and or comments. And while you think of your questions and comments, I just want to remind everyone that this is a CME credited presentation. So please ensure that you have your name listed as the name that you are registered in at the Bahamas Medical Council, and also for you to ensure that you complete the feedback survey that has been placed in the chat. So take the time right now. It doesn't take very long. Use this opportunity while we go through the question comment section to complete the feedback survey. In the chat, we have a comment from Dr. Frankson. Good morning. Thank you very much, Dr. Frederick. Do we have any questions?
I just have a brief question. Thank you, Dr. Fredericks, for a really thorough and comprehensive presentation on fertility, enlightening, eye-opening in many ways. I just had a question concerning uterine artery embolization, which is becoming an option that patients seeking fertility, they would mention that they have fibroids and they're seeking a non-invasive method or minimally invasive, i.e. UAE. And what's the current advice on them taking that option for fibroids if they're seeking fertility?
Okay, sorry about that. Right. So uterine artery embolization, it's something that is very controversial in the management of uterine fibroids in somebody who is trying to conceive, because the uterine artery also gives us a supply to the ovarian artery, to the ovaries, yeah, ovarian artery. And if you damage the uterine artery and you damage this supply, then it can affect your ovarian reserve. So I'm very cautious in patients who are seeking uterine artery embolization as a modality of treatment in patients who are trying to conceive. Uterine artery embolization also, if the fibroid is extremely big, it may not be able to decrease the symptoms that are related to infertility. So my thoughts on it are to, I would be very cautious in my use of uterine artery embolization in somebody who is trying to conceive.
So, I mean, cautious. Obviously, there's a certain operator dependability, whoever the surgeon is and which vessels he's including. But as the OBGYN, we have no control over that. And the patient would seek frank advice. Doc, I have these fibroids. Should I go
Mhm.
for open
Okay,
myomectomy versus UAE?
right. So uterine artery embolization is done by the radiologist. So it's a radiologist normally who would perform this procedure. So, well, you're asking me if I recommend it or not, and I would say I don't recommend it in patients. And if they are insisting on using it, I will explain why, it may be an issue later on in terms of fertility. Does that answer your question?
That does. That does. That's exactly what I was
Okay,
seeking. A frank,
right.
because that's the way
Yes.
the question would be framed to the gynecologist. Should I do this or not?
Right. And I would
Yeah.
say I don't recommend it because I believe that it can have some impact on your ovarian reserve. And when you decrease your ovarian reserve, there's no coming back from that.
Yeah. Thank you.
You're welcome.
Okay, thank you for that. We have some other comments that has popped up in the chat. Great presentation, Dr. Frederick. Excellent presentation, very detailed. Excellent discourse, Dr. Frederick. Excellent presentation. So we have a lot of comments reflecting the wonderful presentation that you would have provided to us this morning. And oh, we have another one. Very thorough. Thank you. We are very grateful again, Dr. Frederick, for your taking the time to. Oh, we have a question that came in for you very quickly because we are past time now.
Okay,
Can you
sorry.
explain
The zymote.
Zymot?
Okay,
Yeah.
so the zymote basically is just a chamber. You can look it up too. It's a chamber that you purchase, and you basically, it has an inlet where you drop the sperm into the inlet. And what it does is that it has a membrane, right? That the sperm now, the motile sperm, the sperm that are alive and motile, they swim up through this membrane. So it's a form of selection of basically sifting out your sperm, basically so the ones that are dead, the ones that have issues, high DNA fragmentation, the ones that have poor motility, it will stay at the bottom. And the ones that are superior will swim through the membrane and they will now settle on the surface. And then there is a outlet port where you actually use now a pipette or a catheter and pull up the sperm from that inlet. So basically it's a form of selection of the fetus. And so because sometimes when you're choosing sperm for like ICSI, or you're choosing sperm to inject into the egg, you can't recognize a sperm that has an abnormal DNA fragmentation. You can't identify abnormality at the DNA level. All you can do is look and see which sperm looks morphologically normal, has a good head, has a good tail, is moving normally. But then you may be choosing a sperm that has a high DNA fragmentation. So it is superior to the traditional methods in that this chamber now selects the highly superior sperm, and so therefore it is associated with a higher pregnancy rate because now you're using sperm that more than likely doesn't have an issue at the level of the DNA.
Okay, thank you. And we have a final question that came in. Do athletes have a higher incidence of infertility?
Athletes, well, no, I would say no to that. Athletes don't have a higher incidence. Actually, if you were to choose an athlete, so you would choose two women with the same age, the same AMH, the same antral count, but one of them is an athlete and one of them is sedentary, we found that actually the athlete will have a better prognosis than the patient who is sedentary.
Okay, thank you. Thank you. And I'm being advised that this talk of fertility, infertility is now a big talk, as there is even a conference that's coming up to discuss this on April 16th and 19th here at the Atlantis. So, Dr. Frederick, you have been most valuable this morning in imparting your knowledge to us. I'm sure that we are all more well versed on the management of infertility and knowing the information to be able to better direct our patients to the hands of the specialists to ensure appropriate treatment. So, with that, I would like to thank all of you for remaining with us through this wonderful presentation. And I will see you again at our next CME session. Have a good day.
Okay, and thank you. Thank you for having me. Thank you, Dr. Wallace Bain, for inviting me. It has been my pleasure. Take care. Have a good day.